The Recovery Kernel. Substance-Specific Navigation Series. How to recover from benzodiazepines. Using the Recovery Kernel Framework. Xanax, Valium, Klonopin, Ativan, Librium, Restoril, Ambient, Lunesta, Pregabalin, Gabapentin. Warning: harm reduction resource, not medical advice. Crisis, call 911 or text 988. Benzodiazepine withdrawal can be fatal. Never stop abruptly. Every taper requires physician supervision. This guide supports the taper. It does not replace it. A note before you begin. This guide is different from the others in this series in one fundamental way: most people reading it did not choose to become dependent on benzodiazepines. They were handed a prescription. For anxiety. For sleep. For a panic attack in an emergency room. For a back spasm. For the aftermath of a traumatic event. They took the medication as directed by their physician, and over weeks or months, sometimes faster, their brain adapted to it. The GABA-A receptors downregulated. The endogenous calming system went quiet. The medication stopped working the way it had. The dose increased. And somewhere in that process, without a moment of deliberate decision, a physical dependence formed. The compendium calls this the iatrogenic wound, when treatment is the harm. Not malpractice, necessarily. Not negligence, necessarily. Just a predictable biological consequence of a class of medications that were approved for 6 to 12 weeks of use and then prescribed indefinitely to millions of people without the conversation about exit ever being started. This guide does not ask you to feel guilty about your dependence. It does not ask you to call yourself an addict if that word does not fit your experience. It asks only that you understand the biology of what happened, specifically enough to navigate the recovery with the precision it requires. The benzo taper is the longest, most patience-demanding recovery journey in this series. Some people are on it for 1 to 3 years. The brain's GABA-A system recalibrates slowly. There is no way to rush it that does not produce danger or suffering. The Compendium Centurion Paper 22 calls this the tightest trap: dependence in weeks, recovery in months to years. This guide is built around that reality. It is honest about the timeline. It provides every biological support tool available. And it holds what the compendium holds throughout: the recovery is possible. The brain does heal. The anxiety that existed before the benzodiazepine, the anxiety that the prescription was trying to address, can be managed through means the brain owns rather than means the pharmacy provides. Read Section 0 before anything else. Section 0, Immediate Safety, read this first. Warning: benzodiazepine withdrawal can produce seizures and death. This is among the very few drug withdrawals that can directly kill. Never stop abruptly after regular use. No exceptions. Who must not stop without medical supervision. Classical building the Centurion, the line is clear: everyone on chronic benzodiazepines. If you have been taking any benzodiazepine, prescription or not, daily for more than 2 to 4 weeks, abrupt cessation carries seizure risk. This is not a statistical rarity. This is a predictable consequence of GABA-A receptor physiology. The following groups face the highest risk. Anyone on benzodiazepines daily for more than 4 weeks. Anyone taking high doses: alprazolam above 2 mg per day, diazepam above 20 mg per day, clonazepam above 2 mg per day, or equivalent. Anyone combining benzodiazepines with alcohol, opioids, or GHB. Anyone with a prior seizure history. Anyone with the GABA-2 high-risk haplotype, if known. Anyone whose prior attempts to reduce or stop produced severe symptoms. The path forward for all of these people is the same: a slow, medically supervised taper. Not willpower. Not cold turkey. Not just getting through it. A taper. The compendium is unambiguous: this is the one class where medical supervision is absolutely non-negotiable. If you are currently in withdrawal, Warning: symptoms of dangerous benzodiazepine withdrawal. Call 911 or go to emergency services now if you experience seizure, any involuntary shaking, loss of consciousness, or confusion after stopping or reducing. Severe confusion or disorientation, not knowing where you are or what is happening. Hallucinations, seeing, hearing, or feeling things that are not there. Rapid uncontrolled heartbeat with chest pain. High fever combined with the above symptoms. Mild to moderate withdrawal symptoms, increased anxiety, insomnia, irritability, muscle tension, headache, sweating, are uncomfortable and distressing but are not immediately life-threatening in most cases. They indicate that the taper is moving too fast or that the dose reduction was too large. Contact your physician, not 911, for these. The immediate harm reduction response. If you have stopped abruptly and are experiencing any withdrawal symptoms, do not continue without medical support. Contact your prescribing physician, go to urgent care, or go to an emergency department. Tell them, I have stopped benzodiazepines abruptly and I am experiencing withdrawal symptoms. They can reinstate a safe dose and begin a supervised taper. If your physician dismisses your withdrawal symptoms or refuses to help with a taper, you have the right to a second opinion. An addiction medicine specialist or psychiatrist with addiction experience is the appropriate referral. The Compendium's Protocol 13, the Physician Conversation, provides the framework for advocating for appropriate care. Section 1. What benzodiazepines did to your brain. Classical: building the Centurion, the boot disc that was never planned for ejection. The Recovery Kernel Compendium uses a precise metaphor for what benzodiazepines were meant to do: they are a boot disc. When the operating system crashes, when anxiety, panic, trauma, or insomnia becomes acute, the boot disc stabilizes the system long enough for the real repairs to happen. Then it is ejected. The real operating system runs the machine. What happened to millions of people prescribed benzodiazepines is that the boot disc was never ejected. The taper was never planned. The exit strategy was never discussed. And over weeks and months, the brain quietly reorganized itself around the presence of the boot disc, because that is what brains do. They adapt to their chemical environment. The result is not a character failing. It is GABA-A receptor biology. How benzodiazepines work, and how they create dependence. The benzodiazepine class, a full spectrum. Classical: building the Centurion, half-life is everything in benzo recovery. The single most clinically important variable in benzodiazepine dependence and withdrawal is half-life. Short-acting benzos produce faster and more intense withdrawal. Long-acting benzos produce slower onset but prolonged withdrawal. This distinction determines the taper strategy. The iatrogenic wound, the context that makes benzo recovery unique. Classical: building the Centurion, the cage was legal. It was still a cage. The Recovery Kernel Compendium Centurion paper c. 34 documents what it names the iatrogenic wound, the harm produced by treatment itself. The tremor the author has carried since a 1998 psychiatric prescription. The cognitive impairment millions carry from years of prescribed benzodiazepines. The anxiety that was present before the prescription, and is more severe after it than it ever was before, because the GABA system that was trying to manage it has been further depleted. Benzodiazepine dependence produced by legitimate prescription carries a specific burden that illicit drug dependence does not: the moral confusion of having followed medical advice and ended up in a worse position than you started. Many people with iatrogenic benzo dependence feel betrayed, by their prescribers, by the medical system, by the medication itself. The Recovery Kernel does not ask you to resolve that feeling before beginning recovery. It asks only that you direct your attention toward the biology. The anger is valid. The betrayal is real. The recovery is also real, and it runs on the same neurobiology regardless of how the dependence formed. What the iatrogenic context does change is this: the anxiety that was being managed by the benzodiazepine was real before the prescription and may be more intense after. Recovery must address the underlying anxiety as a medical condition in its own right, not as a character failing or a sign that sobriety is not working, but as the original clinical problem that the boot disc was inserted to manage. Section 2, Your Genomic Blueprint. The genomic profile for benzodiazepine dependence overlaps significantly with the alcohol recovery profile. GABA2 is the primary gene, but with important additions specific to the prescription context and the CYP450 enzymes that metabolize benzodiazepines. Understanding your profile individualizes the taper strategy, the supplement stack, and the anxiety management architecture that will determine long-term success. The DNA testing panel for benzodiazepine recovery. Phenotyping without test results. The compendium's phenotyping tools apply. Did benzos provide profound relief that no other medication achieved? Likely GABA2 high risk plus SAGE COMT. Anxiety management is your primary long-term recovery architecture. Did benzos hit you much harder than you expected at standard doses, sedation, memory gaps, coordination problems at doses others tolerated easily? Possible CYP2C19 poor metabolizer. Essential information for taper prescriber. Did benzos seem to wear off faster than they should, requiring frequent redosing? Possible CYP3A4 ultra-rapid metabolizer or CYP2C19 ultra-rapid. Inform your prescriber, taper schedule may need adjustment. Has your anxiety been present your entire life, before any prescriptions? GABA2, COMT, SLC6A4, and MTHFR variants are all worth testing. The anxiety is biological and treatable through biological means. Have antidepressants failed to adequately treat the anxiety that drove the benzo prescription? MTHFR impairment and the resulting serotonin synthesis deficit is a common unaddressed cause of SSRI non-response. Test and supplement 5-MTHF before concluding that anxiety is unresponsive to anything other than benzos. Section 3, The Taper Protocol. Warning: there is no safe alternative to a slow, supervised taper. Not willpower. Not supplements. Not prayer. Not cold turkey. A taper. Slow. Supervised. This is the most important sentence in this guide and it cannot be said too plainly. The supplement protocol in Section 4 makes the taper more tolerable. The behavioral protocol makes the anxiety more manageable. The natural GABA architecture in Section 6 makes the recovered life more sustainable. But none of these things replace the taper. The taper is the medicine. Everything else is support. 3.1, The Ashton Protocol, the gold standard. Classical Building the Centurion, the work of Dr. Heather Ashton, the map that exists for this territory. Dr. Heather Ashton, a British pharmacologist who ran a benzodiazepine withdrawal clinic for 12 years, documented the first systematic approach to benzodiazepine tapering. Her manual, freely available at benzo.org.uk, remains the most comprehensive clinical resource for benzo withdrawal and is the reference framework for the protocol described here. The Ashton Protocol's core principles. 3.2, Diazepam equivalent conversion table. Classical Building the Centurion, know what you are taking in common currency. All benzodiazepine doses are converted to diazepam equivalents for taper planning. This table allows you to understand your total GABA-A burden before beginning. Use this to inform the conversation with your physician, not to self-prescribe. Warning: these are approximate conversions. Individual responses vary significantly by genetics, duration of use, and metabolizer status. All conversions must be supervised by a physician familiar with benzo tapering. 3.3, The Withdrawal Timeline. 3.4, Protracted benzodiazepine withdrawal syndrome. Classical Building the Centurion, the waves that come after the shore, real, named, and temporary. Protracted benzodiazepine withdrawal syndrome, PBWS, is one of the least recognized and most distressing experiences in addiction medicine. It occurs in a significant proportion of people who have used benzodiazepines long-term and can persist for 12 to 24 months after the last dose. Its symptoms appear and disappear without predictable pattern, windows and waves experience that can produce profound confusion about whether recovery is actually happening. The compendium's position, PBWS, is a documented neurological phenomenon. It is not anxiety disorder relapse. It is not evidence that benzodiazepines are needed permanently. It is the GABA-A system completing its recalibration on its own schedule, which is not the patient's preferred schedule. Symptoms of PBWS can include waves of intense anxiety or panic, tinnitus, ringing in the ears, visual disturbances, depersonalization and derealization, cognitive difficulty, word finding, memory, emotional numbness alternating with emotional flooding, and hypersensitivity to sound, light, and movement. Any of these can appear suddenly, last hours to days, then resolve, only to reappear weeks later. The response to a PBWS episode: execute Protocol 01, shelter. 478 breathing. Magnesium. L-theanine. Contact your physician if symptoms are severe or include any neurological symptoms you have not experienced before. Do not interpret the episode as evidence that you need to reinstate the benzodiazepine. This is the most common and most costly response to PBWS. Section 4, Biological Reconstruction, the Taper Support Stack. The supplements and interventions in this section do not replace the taper. They make the taper more tolerable, support GABA-A receptor recovery, address the underlying anxiety biology that benzos were managing, and rebuild the systems that chronic benzo use suppressed. Important: if you are currently on a benzodiazepine taper managed by a physician, discuss all supplements before starting. Some, valerian root, kava, high-dose taurine, have GABA-modulating effects that can produce oversedation if combined with active benzodiazepine doses. 4.1, the Methylation Foundation. Identical in structure to the alcohol and GHB guides because the GABA system's recovery depends on the same methylation infrastructure. With one benzodiazepine-specific addition, the cognitive impairment of long-term benzo use is B-vitamin dependent, and aggressive methylation support drives faster cognitive recovery alongside GABA-A restoration. 4.2, GABA-A system restoration support. Classical building the centurion, supporting the recovery the taper is driving. The compendium names the GABA restoration support stack for benzo tapering explicitly: magnesium glycinate, L-theanine, taurine, valerian root, and phosphatidylserine. This section expands each with benzo-specific context and adds additional evidence-supported options. Warning: timing note: all GABA-supporting supplements should be discussed with your physician before adding during an active taper. Some, especially valerian root and taurine at high doses, can enhance sedation. Add one at a time and assess response before adding the next. 4.3, Anxiety Management, the underlying condition. Classical building the centurion, the prescription was trying to solve a real problem. Recovery must solve it differently. The anxiety that drove the benzodiazepine prescription is the central challenge of benzo recovery, not only because it made the prescription feel necessary, but because it will return in full force during the taper and may be more intense in early recovery than it ever was before the prescription. This is not evidence that recovery is impossible. It is evidence that the anxiety was biological all along and that the benzodiazepine was treating it pharmaceutically without addressing the underlying biology. Recovery is the process of building the biological and behavioral infrastructure to manage the anxiety through means the brain owns. 4.4, Cognitive Recovery, the benzo fog clears. Classical building the centurion, the brain you had before the prescription is still there. It is coming back. Long-term benzodiazepine use produces measurable cognitive impairment, benzo fog, that affects memory, processing speed, attention, and word retrieval. This is one of the most distressing aspects of benzo dependence because it is often invisible to prescribers and dismissed as anxiety rather than recognized as pharmacological impairment. The good news, documented in the neuroimaging literature: cognitive function recovers substantially with sustained abstinence. Most impairment resolves within 3 to 12 months after the last dose. BDNF-driven neuroplasticity is the primary mechanism of this recovery. Exercise, the single most powerful BDNF driver. 30 plus minutes aerobic exercise daily produces BDNF increases of 200 to 400%. This is the primary cognitive recovery intervention and it is available to everyone. The benzo fog clears significantly faster in people who exercise vigorously throughout the recovery period. Learning challenging new skills, novel skill acquisition drives BDNF in the specific brain regions involved. Learning an instrument, a language, a craft, or a complex physical skill, anything that requires attention and generates errors to correct, stimulates the neuroplasticity that underpins cognitive recovery. Alpha-GPC or CDP choline, 250 to 500 mg morning supports acetylcholine production, the neurotransmitter most directly associated with memory and learning. Benzodiazepines impair cholinergic function. Supplementing the precursor supports the recovery of memory encoding capacity. Lion's mane mushroom, 500 to 1000 mg daily NGF stimulation driving neurite outgrowth and cognitive plasticity. Particularly relevant for the memory and cognitive impairment of long-term benzo use. DHA, 1000 mg plus daily structural component of neuronal membranes, supports BDNF signaling, anti-inflammatory effects on the neuroinflammation that accompanies long-term GABA system disruption. 4.5, Sleep reconstruction. Benzodiazepine use suppresses REM sleep and stage N3, deep sleep, the two most restorative sleep stages. The insomnia that benzos were prescribed to treat was often replaced by sleep that felt longer but was neurologically impoverished. Recovery involves the return of genuine sleep architecture, often preceded by a period of rebound insomnia that is the brain's attempt to reclaim the REM sleep it was denied. Melatonin, 0.5 to 1 mg sublingual, 30 to 60 minutes before target sleep. Low dose. High doses disrupt rather than support circadian rhythm. Magnesium glycinate, 400 mg elemental, 1 hour before bed. GABA-A receptor stabilization and glutamate reduction directly addresses the hyperexcitability that prevents sleep in benzo recovery. Glycine, 3,5G, 30 minutes before bed. Core body temperature reduction, the primary physiological sleep trigger, plus NMDA modulation supporting GABA-glutamate balance. L-theanine, 200 to 400 mg evening. Alpha wave promotion, reduces anxious hyperarousal that prevents sleep onset. 5-HTP, 50 to 100 mg evening. Serotonin precursor converting to melatonin, supports both mood and sleep architecture recovery. Do not combine with SSRIs without physician guidance. Tart cherry extract, 480 mg or 240 ml juice, evening. Natural melatonin source plus anti-inflammatory. Support sleep without REM suppression. Also execute Protocol 17, Sleep Architecture, from the main compendium in full. The benzo-specific expectation, rebound insomnia is normal and temporary in the weeks following the last dose. It is the brain reclaiming its REM architecture. Do not interpret this as evidence that benzodiazepines are needed permanently. 4.6, Peptide support layer. Physician discussion required for all peptides, research compounds. Section 5, The benzo craving, understanding and interrupting. Classical building the centurion, the benzo craving is usually anxiety, the same anxiety the prescription was managing. Benzodiazepine cravings are unique in this series because they are rarely experienced as wanting in the way opioid or stimulant cravings present. They are more often experienced as anxiety that becomes intolerable, a pause wave that feels exactly like the pre-prescription anxiety, insomnia that seems impossible to survive without medication, or the simple, compelling logic that a pill would fix this immediately. Understanding this reframing matters. You are not craving the drug for its euphoric properties. You are experiencing the withdrawal of the drug's anxiolytic effect, and your brain is presenting the most efficient solution it knows. The interrupt protocol is not fighting a craving. It is providing an alternative anxiety relief response fast enough that the automatic path to the medication does not execute. The benzo craving interrupt, 5-minute protocol. Execute this the moment the "I need the medication" signal fires. Name what is happening. Not, "I need a pill." What is the underlying state? Anxiety spike. Pause wave. Insomnia at 3 a.m. Sleep deprivation amplifying everything. Tinnitus. Naming it separates the state from the action. Execute 4-7-8 breathing, 6 cycles. Not 4. 6. The benzo craving/anxiety state requires more parasympathetic activation than standard anxiety. The additional cycles provide additional GABA-adjacent calming through vagus nerve stimulation. Do not skip this step or abbreviate it. Take L-theanine 400 mg and magnesium 400 mg. These are not placebos, they are your first-line non-pharmacological GABA support. The relief is genuine, if slower than a pill. Orient to your environment. Name 5 things you can see. 4 you can physically touch. 3 you can hear. 2 you can smell. 1 you can taste. This is not a therapeutic exercise, it is a prefrontal cortex activation technique that interrupts the amygdala-driven, take the medication response by engaging the thinking brain. Make contact. Call your prescriber if the symptom is new or severe. Call your support person if it is anxiety or pause. Call 988 if you are in crisis. The isolation of benzo withdrawal amplifies every symptom. Contact is intervention. Execute your natural GABA activation. From Section 6, breath work, cold water, gentle movement, restorative yoga, NSDR. These are not distractions from the anxiety, they are alternative activations of the calming system that the medication was pharmacologically forcing. Document. Trigger, type, intensity, 0 to 10, action, outcome. The benzo craving/anxiety pattern documented over weeks reveals the specific triggers, times of day, and contextual factors that are driving the difficulty. This data is the most useful clinical information you can bring to your prescriber or therapist. The highest risk situations for benzo relapse. Acute stress events, the first time a major stressor hits during recovery, a job loss, a relationship crisis, a health scare, the nervous system's trained response is the medication. Have a plan for stressors before they arrive. Who will you call? What protocol will you execute? Pause waves, the sudden, unpredictable anxiety waves of protracted withdrawal are the most common relapse trigger for long-term benzo recovery. Each wave feels like evidence that sobriety is not sustainable. It is not. It is evidence of a brain recalibrating. Sleep deprivation. Sleep deprivation amplifies every benzo withdrawal symptom and makes the medication logic compelling. Protecting sleep during recovery is medical priority, not lifestyle preference. Prescription renewal temptation. Many people in benzo recovery are still prescribed benzos or have access through their prior prescription. The medication's continued presence and accessibility is a unique relapse risk factor. Discuss with your prescriber the appropriate management of remaining medication supply. New prescribers. Physicians who are not aware of your recovery may prescribe benzos or Z-drugs for anxiety or sleep without understanding the implications. Disclose your recovery history to every prescriber. Carry a note in your medical record if possible. Section 6, Building Your Own GABA, the Natural Calm Architecture. Classical Building the Centurion, Centurion Paper C28 applied to benzo recovery, the system you were born with. The benzodiazepine gave you something specific, a nervous system that would stop. Not slow down, stop. The racing thoughts went quiet. The body unclenched. The alarm system standing perpetual watch went offline. For someone who had never experienced that quiet before, whose nervous system had run chronically hot for decades before the prescription, this was not recreational. It was revelatory. The Recovery Kernel's position on this, that state is yours by biology. Your nervous system was designed to produce it. The conditions under which it does so are specific and learnable. What benzodiazepines did was provide a pharmaceutical override that delivered the state without the conditions, and in doing so, decommissioned the system that would have built the conditions for itself. What you are building in Section 6 is the conditions. The natural GABA architecture. The life that your nervous system can inhabit in stillness, not because it is medicated into quiet, but because it has learned to generate quiet. The natural GABA architecture, what builds it? The sage constitution's long game. Classical building the centurion, the nervous system that ran hot is learning to run right. The sage brain that drove benzodiazepine use is not broken. It is the same brain that produces the deepest thinking, the most sustained creative work, the most careful analysis, and the most nuanced emotional experience that human biology generates. Its cost is the chronic heat of a system that never fully quiets. Recovery does not change the constitution. The brain will always run warmer than average. The dopamine will always linger longer. The stress chemicals will always have more time to accumulate before the COMT enzyme clears them. This is the hardware. It cannot be changed. What can be changed is the relationship with the hardware. The person who spent years borrowing pharmaceutical quiet now has the opportunity to build something the pharmaceutical approach never provided, earned quiet. The stillness that comes from having practiced the conditions for stillness until the nervous system generates them automatically. That is the sage's long game. It is more demanding than a prescription. It is also more theirs. Section 7, Navigating the Recovery Kernel, Your Protocol Map. Section 8, The Medical Support Layer. Benzodiazepine recovery is the area of addiction medicine where the relationship between patient and prescriber is most fraught and most critical. Many people with iatrogenic benzo dependence have had their concerns dismissed, their withdrawal denied, or their request for a taper refused. This section provides the clinical framework for productive advocacy. Non-benzo medications for anxiety during recovery. Advocating for appropriate care. Classical building the centurion, the physician conversation, Protocol 13 applied to benzo recovery. The compendium's Protocol 13, the conversation with your physician, is directly relevant here. Key points for benzo recovery specifically. Bring the benzo.org.uk Ashton manual to your appointment. Print the relevant pages. Ask your physician to read the taper schedule before the appointment. This frames the conversation on evidence rather than opinion. State clearly, I have developed physical dependence on benzodiazepines. I would like to discuss a supervised taper using the Ashton Protocol framework. This is a clinical statement, not an accusation. If your physician denies that benzodiazepine dependence is possible with prescribed use, you are not getting appropriate care. Seek referral to an addiction medicine specialist or a psychiatrist with benzo taper experience. Request CYP2C19 testing before the diazepam crossover. This is clinically indicated and affects taper safety. Frame it as, I want to ensure the taper dosing is appropriate for my metabolism. Document everything, keep records of your doses, taper schedule, symptoms, and all physician communications. This protects you and provides the data your physician needs to optimize the taper. The Benzodiazepine Information Coalition, benzoinfo.com, and the Benzo Buddies community, benzobuddies.org, provide peer support and physician referrals for benzo taper. These resources exist because the medical system has failed many people in this situation. A final word. Classical building the centurion, the boot disc was inserted to help you. Recovery is learning to run without it. The Compendium Centurion Paper 22 closes with these words, the question isn't should I take medication? The question is what is the plan? Before you fill the first prescription, ask, what is my exit strategy? If there isn't one, you're not being treated. You're being maintained. And you deserve better. If you are reading this guide, you may have been maintained for months or years. The exit strategy was never explained. The taper was never offered. The biology of what was happening to your GABA A receptors was never described. You were given a boot disk and told it was an operating system. The recovery kernel was built for this. For the person whose dependence formed not from recklessness but from following medical advice. For the person whose anxiety is real and biological and was being managed by the only tool that seemed to work. For the person who has been told that what they are experiencing is not withdrawal, when the neurophysiology is unambiguous. The taper is the path. It is long. It is demanding. It requires more patience than almost any other recovery journey in this series. And it leads somewhere genuinely different from where the prescription does. It leads to a nervous system that generates its own quiet. To an anxiety response that rises and falls within the range the brain was designed to manage. To cognitive clarity that the benzo fog was obscuring for years. To the earned stillness that is more yours than any pharmaceutical version ever was. The boot disk is being ejected. The operating system is learning to run the machine. Ashton Manual, freebenzo.org.uk Benzodiazepine Information Coalition, benzoinfo.com Benzo Buddies Peer Support, benzobuddies.org. Refer to the Recovery Kernel Complete Centurion Compendium for all referenced protocols. Crisis, call or text 988 Emergency, 911 SAMHSA, 1-800-662-4357. Warning: harm reduction resource, not medical advice. How to recover from benzodiazepines using the Recovery Kernel Substance-Specific Navigation Series.